Thank you very much, Mark. We're relatively on time. If I could ask Mark and David to go up to the front of the room, I think their name tags will be coming shortly. And Ryan, you still on the phone?
I am.
Oh, great, great. Well, we can almost see you up there. Um, I think our speakers, what I would say is our three speakers have summarized uh, interesting, provocative health outcomes and data. I and you know Ryan and Mark to some extent talked about controlled exposure designs essentially, and which may well be crossover designs. But I think the real challenge to us is to figure out research or analyses that will be useful to the regulating community to show that these things actually do emanate from indoor exposures or that they do not. And I'd like to ask our speakers, and they've already started to talk about this, to talk about how you would, to me, the issue is not the outcomes. We have lots of outcomes that we can measure. The issue is how do we relate outcomes to indoor exposures as distinct from outdoor exposures, ambient exposures. And so I'd like to hear, if you have some thoughts based on, David, I think you're the only one who had the benefit of all of yesterday's discussions of exposure kinds of measurements and determinants of indoor exposure. But I'd like to hear people talk about, because, well, that's enough from me.
So I guess since I got to hear you guys talk yesterday, that means I get to go first, I guess. Um, yeah, I mean, I think this is the kind of the questions I was having, and I was talking to different people about is what are the different measures you kind of that we talked about yesterday that everyone has kind of their favorite kind of their area of indoor PM. But essentially, if I was designing a study, and you could do it, I could think of how to do it for cardiovascular, for reproductive, or certainly for neuro. If you're going to be doing something, and even in a cohort approach, or even over short term to look at biomarkers, it's really a question of how many people do I need um, to have adequate power for my outcomes and to look at indoor PM. I might need a few hundred people. So some of these things that we talked about yesterday, also the thing to throw in there is we need something that's certainly validated as a marker of different PM sources, perhaps indoors, but also something that can be done relatively inexpensively, because you can't, we can't be measuring thousands of dollars for each person to each sample, just for a few days when you're going to have to do 500 or 600 people or something. So if you choose that kind of a cohort design, you need to have that kind of cost thrown in. As well. But I think those are the questions I was asking when I was thinking about birth outcomes, was having a suite of indoor exposure, internal dose markers, something you could measure in the blood or urine, as well as just indoor PM and indoor fine particle counts. But I guess that's what I'd be thinking of, but I was kind of thinking the same question Howard was, and I'd want to hear, well, what are some other things that are reasonably inexpensive, logistically, could be put in someone's home without a lot of effort, that could benefit us and tell us a little bit about health effects with indoor PM. So I don't know, I guess I'd ask the question back to the other people in the room.
Mark, do you want to say
So I guess
something?
Go ahead, Ryan.
just a couple quick thoughts. I think it's important to keep in mind that the epidemiology that has been done, the epidemiology that Mark and David talked about, is in a way addressing indoor exposure, right? I mean, people spend 80 or 90% of their time indoors, so even when we see a signal from ambient PM, that has real relevance to what's happening inside people's homes and inside people's workplaces and that sort of thing. And the other comment I would make is, I see this as, as I sort of alluded to in my talk, I see this as largely, an exposure assessment issue. And, I can't remember who it was showed the map, the spatiotemporal, model of the U.S. PM based estimating PM 2.5 concentrations. And as I was looking at that map, I was thinking, boy, wouldn't it be great if we could actually, model indoor PM in the same way. And one thing that we've explored without a great deal of success is to look to see if we can actually build models based on readily available data. So I was involved in a study in British Columbia where we actually looked at tax records and data on different parcels of land, so sort of data for each piece of property, and look to see if there were variables in those tax records that could allow us to predict the infiltration of PM, so the age of the home and those types of things. And we found that we could do it. It wasn't good enough to use in an epi analysis, but it showed some promise. So maybe something along those lines where we can explore other sources of data that help us to understand residences and what's going on inside residences as well as the infiltration of outdoor pollution indoors.
Yeah, so just to build on that, and again, I apologize for not having been able to be here yesterday, but so the only issue, though, I agree with you, Ryan, on that. I mean, the issue that I guess that I see is a lot of those types of factors. What you're going to be doing is sort of seeing how well, essentially, your ambient model predicts for a given individual, and so with certain variables, it might be, well, it doesn't infiltrate as well, and so you don't have as good an ambient predictor, but that doesn't necessarily mean that's going to get you the indoor level, the indoor specific part. So to me, that definitely seems difficult. And I mean, the things that go through my head are obviously exposure assessments approaches, ways that you can, get at what is specific to the indoor part. You're probably still going to want to have the ambient stuff so that you can actually separate that out if you really want to focus on what's just coming from the indoor. But it's at two levels. On the one hand, you could do very, I mean, my initial reaction goes right to personal monitoring because you've got I don't, off the top of my head, see a way to do sort of a U.S. model of indoor air pollutants, but the personal modeling gets you into this problem that then you have to worry about, well, what's the person doing and how is that affecting the outcome you're thinking? So that's why I turn to these sort of case crossover, for lack of a better word, that Ryan talked about and what I was mentioning at Syracuse. For short-term effects, I think is a very good way to go, or the filter thing Ryan was talking about, removing in certain settings. The more you can do that without them, they didn't know whether the filter was in there or not, so that's a good thing. I mean, from a larger cohort perspective and trying to say, if we want to look at Alzheimer's disease or Parkinson's disease, it's going to have to be things where maybe there are some smaller studies that say, what are the sort of simple questions I can ask about their indoor environment on a questionnaire that give me some relation to the indoor air particulate levels? And yes, that's probably not going to be great, right? There's going to be error in that. But if small validation studies can be done to say, such and such questions will get you, part of the way there, then if we have a large enough sample size, we can take advantage of that. And then the example I think Ryan gave of the incense is, of course, one of them, but there may be other factors. So.
Can we open questions up to the room? Yes. Oh.
I'm Arnie Schwartz from George Washington Medical Center and the Milken Institute of Public Health. Thank you so much. This was a very, very productive morning. I have really one question, but in three parts for all three speakers. So the first, and they're all linkage or causality questions, and I think that introduction was brilliant on that part as well. The first is, are there markers in terms of indoor pollution, or for that matter, the linkage between indoor and outdoor pollution with atherosclerosis from the cardiovascular point of view? For your talk on reproductive issues, when you look at your inflammatory markers, do you see correlations between the inflammatory markers found in placental tissue as opposed to found in the blood? And in fact, are there morphological changes within the placenta that correlate with those inflammatory markers? And for your talk, which was really brilliant, are there indications that you have correlations with pollution with olfactory nerve dysfunction?
Do we have a response?
I could go very quickly. Yes, we do with olfactory function. We just recently published on lead. We don't have a quite large enough data set. I haven't looked at it with our ambient air pollution exposures yet, but the number of people we've done this, there's sniff test kind of thing. We have not done those analyses. I don't know if they'd be large enough to see things, but certainly in different, especially occupational settings where you have things like manganese or lead, absolutely there are effects on those. And they also are, olfactory dysfunction is a rather nonspecific but very commonly found precursor to things like Alzheimer's disease and Parkinson's disease. So people lose that function very early.
Yes? Just lean over somebody.
Or stand at the podium.
Hi, I'm Paula Olszewski from the Alfred P. Sloan Foundation in New York. These are fascinating talks, something I know very little about. Is anybody studying the effect of PM on the human microbiome?
Well, we're toying with it, but it's not really in an indoor air context. What can I say? We're doing some pilot studies at Rutgers.
I mean, I've reviewed a few grants looking at that, but I haven't seen anything out. People are looking at it, yes.
Bill Fisk, Lawrence Berkeley Lab. Technically, you couldn't necessarily do a big enough population. Technically, you can separate exposures to indoor and outdoor PM using filtration. So you could find a buildings, and use filters and pressurization to basically eliminate exposures to outdoor particles, and then you can use filters or source control to change exposures to indoor particles. The question is, can you do this with a big enough population? You'd probably start with maybe an elderly population with certain diseases or so forth, where medical records are already kept. But I think we ought to think about those approaches. But my other comment is, these were just wonderful talks, but there was no discussion, and I hope somehow it gets into the record of this workshop, of sort of allergy and asthma outcomes in indoor particle exposures. And I just think, it's too important to not either have a discussion of that in the output of this workshop, or to note very explicitly that it wasn't covered in the health sessions here.
Well, I'll just say, we did consider some speakers who have that type of expertise. We didn't end up selecting them, but you're right. They're very important outcomes. But at this point, I would say, other than some mention yesterday, they're relatively uncovered by what we've done. Yeah.
I think also they're a little more well received, and there's been a lot of work there. I think certainly it started, a lot of the air pollution work starts with pulmonary outcomes, and it went to cardiovascular, then it's gone to neuro and reproductive. So I think there's a huge body of work. So I guess we're kind of more in looking at these other outcomes, which are newer in a sense. So I don't think, at least for me, I don't think there's any question as to whether or not there's that relationship between those outcomes and PM, even specifically indoor. But I didn't, just to make sure we addressed your questions, I didn't want to not answer you. In terms of looking at effects on the placenta, specifically in inflammatory markers, we've just proposed that, but there's really not anything out there that's specifically looking at whether or not inflammation in the mom gets to the placenta, and then that inflammation in the placenta causes either some sort of abnormal development, or that leads to effects on the fetus in whatever form. That work hasn't been done. There's pieces like what I was showing you about the Van den Hooven study, and there's a few others like that, but not something that ties that all together. So hopefully that's coming soon.
And I would add to that actually it's a very important interest of mine as well, because our autism work, I think, is pointing to the pregnancy period, and I said specifically third trimester possibly, but if that's the case, all this stuff about olfactory bulb and getting directly into the brain, that's not happening in that setting. It's getting to the mother, and somehow some effect must be happening, and so presumably somehow through the placenta or something passing there and then disrupting neurodevelopment in the child would be happening at that stage. It may also be happening afterwards directly to the child, but I think there's certainly a maternal component, which presumably would mean we should be looking at that.
And I think there was a question in there as well about, if I understood the question properly, about indoor PM and atherosclerosis. and you know, I'm not aware of any research explicitly looking at that link. But of course, some of the more intermediate outcomes that I mentioned, inflammation, for example, plays an important role in the development of atherosclerosis, as you know. And then, you know, you could sort of think of endothelial function and kind of arterial stiffening as maybe the earliest stages of the development of the atherosclerotic plaques. So you know, not explicitly looking at atherosclerosis, but certainly I think mechanistically it would make sense if such a link did exist.
Thanks. I know we have more questions in the room, but I want to take our web, give priority to our web questioner. We have one, and then we'll come back to the room.
Thanks. This is a question from Steve Temis. He writes, are health effects thought to be caused by the neurologic irritant effect of particles or by the chemical composition of particles, which is still relatively unknown?
Well, regarding the neurological side of things, first, we don't know a whole lot yet, but I would say probably both, right? So I think there's the irritant and then inflammatory cascade and microglial effects and things of that sort. But certainly, if particular components could come in, I mean, you might have a metal coming in, and we know there's a ton of literature on lead, and it directly affects certain receptors and enzymes and mix calcium in the brain and can gum up all sorts of work. So I think it is probably both. Things can be, there may be particular components that come in that have very specific effects on certain enzymes or receptors, and then I think there's also a general inflammatory effect that can play a role, in the brain anyway.
Any other comments on that one? Barbara, you had a question?
I'm just in a sense responding to an earlier comment about questionnaires. So there's a lot of data where PM was measured at the same time as a lot of questionnaire data about people's activities and about sources in the home. And for the most part, you know, if you're talking about 24 or 48-hour average PM, there isn't a very strong association between those concentrations and particular activities and sources in the home. And I think that, you know, that's because largely those activities and sources are really short duration. And if you want to see a strong association, you need to be looking at real-time PM measurements, you know, short duration, or if you go to the other extreme, you know, the incense example is a good one, where if you're just saying, you know, here's an everyday long-term exposure, then I think you might have some luck in terms of using questionnaire data instead of PM measurements.
Let me, Joe, you had a question long ago.
Comment with respect to the indoor PM measurements. There's a monitoring system now called the SPEC that was developed at Create Labs at CMU, and it's a low-cost sensor that may be helpful with future studies. It's $200. They actually put them in libraries so people can check them out, and it all gets uploaded, or it can be uploaded to the web. And I don't know if there's some way you could kind of combine what you're doing with what they're doing to help you. PM 2.5.
I was going to say that there's a study ongoing now. Andrea Farrow is leading at Clarkson, looking at, it's targeted more at wood smoke, but also at PM 2.5, that's trying to use and develop some of these low-cost sensors, measuring both indoors and outdoors and looking at those types of relationships. So I think she's just in the first year of it, so hopefully there'll be some work there. And again, there's not a health component to that. That's purely just looking at exposure and do these sensors work and can they be used logistically, practically for such kind of a panel study approach.
Yep.
So actually, and I really am sorry that I missed yesterday, because I don't know whether this kind of thing would be talked about. But so I have a question, whether this was talked about or if people know. I mean, let's take a building like this one, right, built new. Presumably there are filtration systems. It's probably reasonably tight. So are there, as the air is, you know, exchanged in this building, is there no sort of filter or something that could tell me on a month-to-month basis how much PM had to be filtered out of the building as the air exchanged? And then I can now use, I mean, we spend most of our time in our office, so I could use where do you work, and if there's a system of that, I could take that for different office buildings, place people in those, and use that as an exposure measure.
Okay, who's going to answer, who's going to speak for the NAS? Bill?
Yeah, Bill Nazaroff. So I think we actually know quite well. It was discussed substantially yesterday how to estimate the indoor exposure in a mechanically ventilated building to particles of outdoor origin. And sort of fairly straightforward model with knowledge of the airflow rates and the filter efficiency. Um, at the level of individual buildings, there's going to be some classification error, but if the study's big enough, I think you could do it. The total exposure that one gets, you know, people may spend a lot of time at their office, but they spend more time at home, and so what happens in the home would be an important part of the story to try to take account of. I'm actually optimistic about the potential, and I think we have something more of a community systemic problem where there's not enough communication between, you know, particularly ISEE, ISEA, they seem to be talking to each other, ISES, talking to each other relatively well, and then the ISIAC folks who know more about building science and can really help with understanding mechanistically how to get from what's outdoors and what goes on indoors to estimates of exposure. Um, there's a bigger gap in those communities. And for those, I'm sorry, I was not being multidisciplinary enough by throwing around the acronyms. International Society of Environmental Epidemiology, International Society of Exposure Science, and the International Society of Indoor Air Quality and Climate.
I want to try to be
Lynn Hildeman, Stanford University. I'm really intrigued by this trying to identify which sources are more or less impactful on human health. My question for the panel is, have you thought of how much information you might be able to get by focusing on specific occupations? For example, if you did a study where one of the cohorts were cooks, you might get a very good first impression of how important exposure to cooking emissions are in terms of impact on human health.
I mean, I guess clearly those are ideas you could definitely use. You could, and I think more on the reproductive side, because it's one of those where you know you know when the event is going to come. You don't have to enroll, you know, follow 1,000 people to get 100 people that have your event. Everyone's going to have a birth weight. Everyone's going to have some sort of estimate of gestational age. So on the birth outcomes, you could perhaps do that. That'd be kind of a cool idea. But again, you know, I think those are the kind of innovative, novel ideas to try to take first pass stabs at whether or not these sources could perhaps impact.
Yeah, and I mean, so what you're describing is classic occupational epidemiology, right? We take occupations and we know different exposures those occupations have, and we try and relate it to health outcomes. I'm doing that in Denmark, where I have the advantage of they track everything, so I know everything that happens to everybody. So I have 5 million people at my disposal, and I know their jobs, and in fact, they track on a monthly basis, actually a daily basis, what their jobs are. So that is a tremendous opportunity. What I desperately need to go with that is my occupational epidemiologist friend and industrial hygienist who says, you know, we've gone in and taken measurements in these different job settings, and here's what the exposures are. We're doing that now for formaldehyde and lead in different settings. I should ask him whether there is a particulate matter one. I don't know if, but we need, so if there isn't, what we need is people who understand exposure science extremely well to go in and do a very detailed, you know, study that can look at different job settings where we would expect to have a reasonable range of exposures and give me even a, you know, when I'm dealing with 5 million people, it doesn't even have to be that, you know, good, but you need to give me some indication of which are the high, low, and no exposure categories.
Let me just challenge you a little specifically, and I know, David, you're familiar with the design too. If you took something like the Nurses' Health Study, would it be reasonable to, on one of the annual reviews, try to, and I guess this is also for the exposure people, try to retrospectively characterize the residential exposures of those people based on a reasonable number of questions, and then look in essentially in a cohort design for who's been exposed to more indoor pollution of outdoor origin or whatever the questions are designed to estimate, and look at that with in terms of chronic health outcomes, in terms of cardiovascular, not the biomarkers, but the actual health outcomes.
Certainly this is your study, but I can say what I do. I mean, that's kind of what Barb's talking about. In a sense, you could look at chronic, and it's just the first pass saying, or characterize people as to whether or not they regularly do this, regularly do that over the past few months or past 2 years. I think every nurse's health study comes, the questionnaires come. But again, if you're trying to get an idea as to what sources might be important, that would certainly be interesting to do and relatively cheap way to do it. But I think clearly, as Barb's suggesting, some of these things could be very acute effects where that may not tell you as much, and you might be missing a story there by that. So it could be done certainly, but
Yeah, and I think I don't know if Ryan's going to chime in also, but I mean, I think some of the stuff that he was describing, it sounds like he's trying to do with these more maybe administrative records. I can't remember what he was talking about. That, yeah, that might have some information that you could get that from. In the nurses' health studies, aside from trying to get it stuck into the questionnaire, which is a big battle. No, absolutely. And actually, we are now in the process of forming Nurses Health Study 3, which is specifically designed for younger women. So it could be interesting for reproductive outcomes. I mean, they're interested in fertility issues. But yeah, I mean, what we need to know is what are the questions to ask about the home environment, right? Which ones are the biggest drivers of changes in indoor particulate matter. And on the office, I was just thinking about the office side, like this building, right? I mean, I guess one of the issues, I don't know if this was discussed about, but in terms of the filtration and knowing what's coming in and out of the building or coming out of it that was in it, I mean, would that pick up, for example, my understanding is at copy machines, there's a lot of ultrafine exposures that might be actually rather local to the copy machine. I don't know whether you would pick that up, right? So, but for example, if you ask somebody, how many times a day do you go to the copier or something like that. But from the indoor home environment, yeah, the real issue is, what are the questions asked? Does it matter? I mean, presumably, like, is it a gas stove or electric stove? Probably matters. But what are the biggest? So we need the first studies to go into various homes, do very detailed assessments, and say, here, just sort of what predicts the PM level, and what are the ones that account for the most variance, and then can we capture that in a reasonably simple question?
Thanks, Mark.
The other comment I'll make just quickly is, if there's time, is just quickly is, the other thing we have to think about is in an epi study, what we need is exposure variability. So, sort of if everybody's exposed at the same level, you can't do an epi study. You need the exposure contrast. And so when we start thinking about these indoor sources, and someone made the comment earlier, which I think was spot on, that really, we're probably only in these questionnaires going to be able to capture the major sources. We also need to think about whether in a population there's likely to be sufficient variability. So, if everybody's cooking, sort of roughly the same amount in a week, it's going to be more difficult to see associations with health just because the exposure variability within the population won't be there. So one is the ability to predict the exposure. The other is whether there's sufficient variability in the exposure to drive an epi study.
That's a great point. We have another question from the EPA.
Thank you. Lara Cobb, EPA, could you comment on what you think this is in terms of the size of this public health issue? What's the scope of this problem given the information that we have now?
Well, I'll start only because I think, especially when I talk about the anxiety and we're trying to do some stuff on depression too. When I talk about that, the first slide is usually that is an absolutely enormous public health problem. I think, the numbers are something like 1 in 5 will have an anxiety disorder in their life in the U.S. 1 in 4 suffers from one of these big things. I think it's number 1 in disability adjusted life years from WHO. So, I mean, it's obviously not all the environment. I think environmental exposures have been underappreciated in that realm. And, the fact is, with particulate matter, it's ubiquitous. So if it even has a subtle effect on these things across the population, I think it could be quite large, right? And neurologically, I mean, cognitive function, we're in a knowledge workforce, right? If you are knocking down even a few points on IQ, or you're having a bad day in the office because of the particulate matter, that's productivity, right? So I think it could be quite big. I mean, but the other side of that equation is how much is in the homes? How much are people really getting exposed to? And so, I have less of a handle on that because I deal with the ambient stuff more, but that's the other side of the equation.
I'll maybe talk on the. Oh, go ahead, Ryan. Go ahead.
I was just going to say, just to follow on that, I mean, I completely agree. And, I would say that the real thing is we don't really necessarily know whether the kind of concentration response relationships, the dose response relationships, are the same indoors as they are outdoors. But certainly, it's a ubiquitous exposure. There don't appear to be any thresholds. That is, any exposure seems to carry with it some health risk. And then, the third thing is that certainly in the context of cardiovascular, these are very prevalent outcomes. So if you take a prevalent outcome and you increase the risk of it by 5 or 10%, you're talking about a lot of additional cases of that outcome. So I don't think we know, but I think the potential is there for this to be a significant public health issue.
We're out of time, so we're going to give David Rich the final comment on that question and then be offline.
So I was just going to say, in terms of reproductive outcomes, I mean, I think specifically with preterm birth, I mean, that's one of the United States is actually at the higher end of the preterm birth rate around the world. Our Beijing work, preterm birth rate in Beijing was like 3%. In the U.S., it's at 11%. So clearly a public health issue of great importance. And then certainly whenever we think about those types of questions, there's always that, well, we see relative risk estimates comparing people that are exposed and unexposed, but what's the absolute risk? And that has to do what's the probability of exposure in the whole population. And the way I always explain it to my student, you can talk about all the chemicals you want, but in terms of air pollution, everybody breathes. So therefore, everyone, if you're pregnant, you're exposed to it to some degree. So I think absolute risk here for some of these outcomes could be pretty substantial simply because of the just complete exposure that everyone is having.
With this, we'll go into a break until 10:20 Eastern Time. Thanks for all of our Session 5 presenters, especially Ryan Allen, who got up insanely early in the morning to present from Vancouver.
Thank you, Ryan.